Good morning, everyone. And today, this lecture is about neonatal resuscitation. Again, actually, I'm not used to teach on the slide, so this is the slide. First of all, like while talking about introduction, I'm going to scroll it down so that you can have a look on this one. And as soon as I'm going to finish the introduction, then I'm going to start in my own way. Okay, so. Basically, in neonatal resuscitation, the most important thing you can say is Apgar score, okay? This one, the score I'm talking about. And as you know, I told you like the first days of the life, or you can say the first years of the life, is very much related with what happened during the pregnancy. Now, here you can see over here, see, like during labor, labor is a complex procedure, and sometimes, during the labor or before the labor or during the pregnancy, blood supply to the brain can get compromised, okay? And when the blood supply to the brain get compromised, basically what happened is um, it can lead to a permanent type of damage to the brain, which we call it as hypoxic ischemic encephalopathy. Okay, and during the labor, intracranial hemorrhage can occur even after the labor, after the childbirth, especially in premature babies. This thing can occur. So now the important thing to here is to mention is here is what like guys, most of the time, most infants, they don't need any type of resuscitation, but you can say um, like most of the babies after birth, they simply take breath, okay? And they start crying and their color become pink as soon as they are born, okay? But some of the babies, okay, and of course like those babies, as I was talking in my previous lecture, they are handed over to the mother after the pediatricians, they already have checked them, but or like some of the babies, who don't get like who don't establish, you can say, normal breathing or normal respiration. Of course, in those, what we have to do, we have to do resuscitation. In front of you there will be primary apnea and secondary apnea. Don't don't get confused, I will talk about that, not here, but of course in my own way. Okay, so now the important thing to understand is um, what we do in like whenever we are dealing with a newborn baby, and whenever we think, for example, the baby needs some sort of resuscitation, okay? For example, if the baby is not breathing, okay, or the baby is not getting um, like pink color, okay, rather they are blue, or for example the baby heartbeat is less than 110, of course, like that is bradycardia in the babies, okay, the newborn I'm talking about. Then of course we have to do something to try simply to get them back to the normal side, okay? So in that case, of course, we must have some appropriate skills or specialized skills, so that we can do some intervention and we can bring or deal with this these kind of newborns, okay? And to simply minimize the damage in those babies as less as possible, okay? Now you can of course, like that is assessed by the pediatrician, okay? And for like the extreme of everything, and of course just in good facilities, is in endotracheal intubation or intubation, of course, to give them breathing by the help of the ventilator, of course, okay? uh, Now what we are going to okay, there could be many reasons, like meconium aspiration can be there, like transient tachypnea of newborn can be there, like respiratory distress syndrome can be there. It can be a congenital heart condition. It can be the effect of the drugs which we are giving to the mother. It can be some congenital other malformations. Okay, so simply now to start with, guys, um, I'm going to tell you what to do is you can see over here. See, what happens is as soon as the babies are born, okay, what we do, we try the baby, okay, remove any wet towels and cover, start the clock or note the time, okay, and what we do, um, we assess their Apgar score, okay. Now, what is Apgar score? It can be seen over here. Okay. What is APGAR or Apgar? Is simply APGAR. What is Apgar score? It is simply A for appearance, which you can see over here. Okay, the skin color. P is for pulse, which is the heart rate. You can see here. G is for grimace, okay, or like, which is like reaction after stimulate soul or like intubation. A is for activity, like how they are behaving or what is the body tone they have. And R is for respiration, what is like how, what is their respiration effort simply. Okay, so you can see over here the minimum is 0, the maximum is 2 for each category, which means the least score any baby can get is 0. The maximum score which any baby can get is 10. Okay. You can see over here, see, for example, if the heart rate, okay, for example, if we will talk about the skin color, see, or the color or the appearance, if the baby is cyanosis or blue or pale, right, 0. If the body is red but the limbs or the peripheral extremities are blue, 1. If all baby is pink, okay, red is the wrong letter, pink, okay. 2. Heart rate, no heart rate, 0, then less than 101, more than 102. Reaction after like you stimulate or intubate, if there is no reaction at all, okay. uh, if no response is there, so you can write no response, okay, the baby is not responsive, 0. If there is some action, for example frown or grimace, G is for grimace, okay, then it's 1. And simply if someone, the baby, it started crying and the crying is of good quality, 2. When we check the activity or the tone, okay, so if the baby is limpy, if the baby is limpy, 0, okay. If it is showing some flexion of the extremities, 1. If it's active motion, the limbs are actively moving, 2. Respiration, if there is no respiration, 0. If there is slow irregular respiration, 1. If there is a normal cry with normal breathing, then it's 2. Okay, so cry or sneeze, or you can say cry or cough. Okay, it can be sneeze, it can be cough. So see, what we have to do right after the baby is born, we check the Apgar score at 1 and 5 minutes. Okay, we check the Apgar score. We check the Apgar score. Should be assessed. What is this? Okay, wait. Okay, Apgar score should be assessed at 1 minute and 5 minutes. Okay, very simple rule, guys. I will tell you. If Apgar score is less than 7 at 5 minutes. Okay, then you have to keep on assessing the score after every 5 minutes until it is more than 7. This is the most important point to understand. Okay, what you have to do in those 5 minutes, that's a different discussion. See, the baby is born, you started to use the clock. Okay, once you started the clock, in the first 1 minute you are doing all the necessary things. You have to stimulate the baby, you have to clean the baby. If there is any secretion in the mouth, you have to suck that. Okay, suctioning should be done. Okay, at 1 minute you will assess the Apgar score, and if the Apgar score is less than 7, you have to start the resuscitation and keep on doing resuscitation until the Apgar score is more than 7 each 5 minutes. Okay, now see, this is the overview. You can say dry the baby, remove any wet towels, cover, start the clock, or note the time, birth, 30 seconds, 60 seconds. What is this? They are assessing tone, breathing, and heart rates. What they are doing, they are assessing the Apgar score. Open the airway, give 5 inflation breaths, consider oxygen monitoring, reassess if no increase in heart rate, look for the chest movement. If chest not moving, recheck head position, consider 2% airway control and other airway maneuvers, repeat inflation breaths. Okay, these things might be looking very hard for you, but these things are very easy. I will show you why. See, most of the babies, they don't need any resuscitation. Now, the important thing here to understand is what? We should know what babies or what are the groups which need resuscitation. To check the Apgar score is not good. All health professionals dealing with a newborn infant should be proficient in basic resuscitation, airway, breathing with mask ventilation, circulation, and with cardiac compressions. This is the preparation points I'm reading. Additional skilled assistance needed if the baby does not respond rapidly and should be called without delay. A person proficient in advanced resuscitation, again, airway breathing versus tracheal ventilation, circulation, and drugs, should be on site and available at short notice in maternity units all the time. The need for resuscitation can usually be anticipated, and a person proficient in advanced resuscitation should be in attendance at all high risk deliveries. A clock should be started at birth for accurate timing of changes in the infant condition. Keep the infant warm, dry, remove wet towel, replace with dry one. This will also provide stimulation. We were discussing in the last lecture how we can stimulate the babies. Can place directly on mother's chest and covered if crying, good tone and color and desired by the mother. What it means, if the Apgar score is good, you can treat it as a normal baby. Resuscitation should be performed under a radiant warmer so that there should be no hypothermia. If preterm and less than 30 weeks gestation, to avoid heat loss, place the infant in a plastic bag without drying but under a radiant warmer and or on a warming mattress. Leave the head exposed and cover with woolen hat. Assess the infant condition. Is the baby breathing or crying? Good heart rate? Good color and muscle tone. Again, Apgar score. If not, commence neonatal resuscitation. Now, we have to know what is neonatal resuscitation. Guys, one thing which is important to understand here is what? Listen to me. Don't see what I'm doing. Rather, just listen to me. Okay. See, as soon as we are going to find the baby, okay, or we are going to deal with any pregnancy, what is the important thing is the history of the mother should be at our bedside, okay. We should know what kind of problems the mother was having during the pregnancy, okay. We should know uh, uh, simply uh, what were the history of pregnancy, okay. We should know what were the illnesses the mother was having. We should know what was the mode of delivery. Like I'm talking about from the pediatrician point of view. Well, I'm sorry for these baby crying sound. Seems like I'm recording this lecture in pediatrics ward, but which I'm not. This is my own pediatrics, in home. So, uh, see, few things which should be at our hand. Look, as soon as we are going to deal with any baby, the things which you should know before dealing: maternal history, okay, history of pregnancy, what happened during pregnancy, how was the labor, either it's a normal labor, either it's obstructed labor, either there was any special treatment given during labor, of course, when you will study OBS, and how was the delivery, okay, drugs taken by the mother during pregnancy and during labor. For example, if the mother is taking too much painkiller for the labor, like opioids, they can cause respiratory depression, okay. So these things should be at your hand. This information should be ready for you, so that you must know what to do, okay. Now, see, what is resuscitation? I told you, you will warm the baby, you will position the baby, um, position position the baby in sniffing position, okay. This is the sniffing position, this one, like you're sniffing something. So then after that, once we had done that, then we tried to stimulate, and we are discussing what are the ways of stimulation. You can hit the back, rub the back gently, okay, or flick the soles, okay. And this is like, by this way the babies basically they get stimulation, okay. Like some of the babies, they start breathing. Once you had done that, then what we do: airway open by placing the infant's hand in neutral position. Again, the same thing which we already covered in adult medicine: chin lift or the jaw thrust, suction if there is any secretions, of course amniotic fluid. If there is meconium aspiration, of course meconium can be there, okay. And if needed, we can consider an airway. Breathing, if not breathing, start mask ventilation. There is an ambu-bags mask, okay, and mask is placed over mouth and nose, and there should be another person who can use that one. Give 5 inflation breaths, inflation time 2 to 3 seconds, okay. And if heart rate increases but breathing does not start, continue with peak inspiratory pressure to achieve chest wall movements, okay. And begin ventilatory resuscitation in air to avoid excessive tissue oxygenation, okay. Of course, like not using special oxygen. If given additional oxygen, use air over oxygen blender. Of course, we don't want to oxygenate them too much. Reassess every 30 seconds, okay. And intubation, of course, if needed, we can intubate the person, the baby. So, see what we are doing. We are simply doing ABC, airway, breathing, and we are assessing their circulation. Okay, and of course, if someone is not breathing at this time, then you can consider intubation, because you have to go in the same manner. See, airway, make sure it is patent. If not patent, position. If needed, use a airway. Breathing. If not breathing, use ambu bag. Do all the stuff. If it's still not working, intubate. Okay, because if breathing is not maintained, we cannot go on circulation. So intubation and mechanical ventilation, if the baby is not breathing by this way, we can intubate them. Okay, now about the circulation. So if you can see over here what they're saying, see, always needed and really needed. Most of the babies, they don't need anything. Few of the babies, they need like 5 inflation breaths. Very few of the babies, they need check airway and breathing, repeat in inflation breaths. Very few babies need chest compression, and like a very small proportion, they need drugs. Okay, so of course, after this, if you believe or if you think that the circulation is not done, is not happening, what you will do? You will start chest compressions. You can see over here what they're talking about the here is, or what they wanted to show you here is what the steps of resuscitation. Head position, okay, by chin lift or jaw thrust. They are saying the jaw thrust or the chin support. Cover mouth, nose, and chin, but not eyes. Okay, of course this is one is incorrect. Okay, too large covers eyes and extends. Of course this one is also incorrect because this is too small. Okay, not covering the mouth and nose completely. And pressure limited air oxygen. See, this is the right way to cover this. Okay, and this one is like they are doing tracheal intubation. Okay, this one is here they are doing tracheal intubation because of course, like if this thing failed, you can consider this thing. Okay, about circulation, simply guys, see, if the heart rate is not between 110 to 160, uh, then we can go for chest compressions. Okay, or CPR, of course. Or if there is no heart rate, uh, if there is no heart rate at all, of course we can go for CPR. Okay, so you can see here, if we can consider drugs if the heart rate is less than 60 beats per minute, in spite of adequate ventilation and chest compression, though the efficacy of like the evidence is lacking, but of course we can use this one. Of course, they're really rarely needed. Okay, drugs should be given via an umbilical venous catheter, or if possible via intraosseous needle. Okay, so again, like this is a different discussion. What drugs we can use and what are their indications? See, we can use epinephrine in any depressed baby. Okay, by the way, what is depressed baby? I will tell you now. Wait. Okay. Who is a depressed baby? Who is a depressed baby? Okay. See, a depressed baby, a normal baby simply, or you can say it anyways. For example, I will say it like a depressed baby or newborn lacks one or more of the following characteristics. Okay, which are present, of course, in the normal one. So what are the characteristics, guys? See, number one, pulse greater than 100 beats per minute, cries when stimulated, actively moves all extremities and has a strong cry. Okay, these things are present in all the normal babies. Any baby who is lacking one or more than one is called as a depressed baby. So see, any baby, for example, you can see epinephrine. What is the indication of this? Heart rate less than 60 beats per minute, which means that the baby is depressed. Okay, so any baby who is depressed, whose heart rate is less than 60 beats per minute, in spite of adequate ventilation and external cardiac compression, we can use epinephrine. Okay, guys, there is very few drugs in which you have to remember the dosages. Adrenaline is one of them. At this level, most, like, no one is going to ask you the dose of any antibiotic, any drug, but maybe they can ask you the dose of adrenaline. See the concentration, see how much dose we give in IV or through the endotracheal tube we can give. Okay, so what is the indication? If it's a depressed baby, see, I explain you what is a depressed baby. So simply, a depressed baby is anyone whose pulse is less than 100, who doesn't cry when he's stimulated, who is not moving his limbs actively, who don't have a good cry. It's not like this that all these features should be present. Even one feature classify that the baby is a depressed newborn. Okay, it's a depressed newborn. So if the heart rate is less than 60, one thing which we can try, we can give them epinephrine, either IV or either through endotracheal tube. Okay, this is one of the things. We can give the babies or newborns sodium bicarbonate. What is the indication? If they have severe lactic acidosis. Okay, many newborns during labor, when the labor is prolonged, what happens is uh, they go into distress. When they go into distress, what happens is um their body can go into lactic acidosis, which is you can say a global way of checking uh, uh, like how much you can say anaerobic respiration is going inside your body or how much damage is done. Okay, by the way, we had discussed this thing in general surgery already. So what they do, by the way, they can make a small cut on their skull. They can take the blood while the baby is still in the birth canal, and they can see, they can check like what is the level of lactic acidosis. If the level of the lactic acidosis is high, it means that the patient have like severe lactic acidosis. If the level is high, so we can give them sodium bicarbonate. Okay, 2 to 4 milliliter per kilogram. No need to remember the dosage. We can give them normal saline or dextrose, for example. Dextrose, of course, if there is hypoglycemia, and if you are finding that the baby has hypovolemia. Okay, blood loss is not the correct word. You can say any kind of hypovolemia, we can give them normal saline or simply a volume expander. Okay, so these are the indications, guys. So see, the resuscitation things are same. We measure Apgar score at 1 minute. We start resuscitation, check at 5 minutes. If Apgar score is less than 7, we still continue resuscitation. Again, reassess Apgar score at 5 minutes. If it's still the Apgar score is less than 7, keep on starting resuscitation. Okay. So I think now you can understand this overview better. What drugs I gave you the example? Epinephrine, bicarbonate. I gave the example of dextrose. I gave the example of normal saline. More drugs are there. I'm going to discuss them in a while. For example, we can use a drug called as uh, which is the antidote of opioid, but not used much, by the way. Anyhow, now I think you are going to understand this thing better. See, or what is the overview? Dry the baby, remove any wet towels, cover, start the clock, or note the time. See this one. At all stages, ask, do you need help? At 30 seconds, you must have done the tone, breathing, and heart rate. At 60 seconds, if gasping or not breathing, open the airway, give 5 inflation breaths. Consider oxygen monitoring. Very easy. They can put a pulse oximetry and they can start noticing the oxygen level in the blood. Reassess. If no increase in heart rate, look for chest movement. If chest not moving, what you have to do? Head position. Two persons can control the airway and they can provide the inflations. Okay. And of course, if there is, like, we have to look for the response and we have to keep on looking the oxygen saturation. If no increase in heart rate, again, look for chest movement. When the chest is moving, if heart rate is not detectable or slow, start chest compressions. 3 compressions to each breath. 3 compressions to each breath. Okay. Reassess heart rate every 30 seconds. If heart rate is not detectable or slow, consider venous excess and drugs. Okay. Don't waste time to assess Apgar score again and again. Okay. Apgar score, if needed, can be reassessed at every 5 minutes because Apgar score can help you in directing towards, like, either you can stop the resuscitation measures or not. But resuscitation is the main thing which is going to help the newborn. Resuscitation can help them, can save them, can minimize or can make the loss or damage minimal. Resuscitation is important. Apgar score can just guide you towards either your resuscitation measures are working good or not. Okay, or either you have to stop resuscitation measures or not. Okay, I hope you understand. So like, this is, the acceptable pre-ductal, uh, the level of oxygen in the blood. Okay, at 2 minutes, at 3 minutes, at 4 minutes, at 5 minutes, and 10 minutes. Okay, so uh, here basically, they have given what you can say the percentages as single digits, like single numbers, but these are basically ranges. Like at 10 minutes, 85 to 95 is acceptable. At 5 minutes, 80 to 85% is acceptable. At 4 minutes, 75 to 80% acceptable. So you can say that they have given the upper limits, okay, of this thing. Okay, so I hope you understand this thing. This is how we go for resuscitation. Okay, so how we do chest compressions? Simply, ratio of compression. The lung. It's like, as I told you, 3:1. Okay, 30 breaths to per minute we have to give. Okay, and the chest compressions, of course. And I told you, like, how. Okay, so what are the drugs we can give to these babies? Is not needed every time, but of course you must know. For example, there is a drug called as naloxone, and I think, like, many of you are familiar what is naloxone. Any mother, who have taken opiates, okay, like, this is basically opiates antidote. Okay. So the mothers, like, who have taken opiates as a painkiller, one of the side effects of opiates is what it causes: respiratory depression. So if you have a confirmed history that the mother have taken opiates, so, and the baby is not showing enough respiratory effort, we can give them naloxone. Okay, so of course, like, nowadays, because now there is a lot of advances in drugs and in gynecology and in obs, nowadays these drugs are not needed much, because like they can give the mothers drugs which don't cause much things or much effects in the babies. Okay, so this thing is important, guys, the resuscitation, uh, and to tell you the important thing, if you think, for example, I just told you like when to stop resuscitation, when the baby is revived, is doing good, that's it. uh, One of the question which will be coming into like mind of you, like in your mind, is when to give up or when to stop resuscitation, or when the baby is not responding to resuscitation simply. Okay, like one condition is this thing: you did resuscitation, the baby, the newborn, it's his Abgar score become good, and you stop because now the newborn doesn't need any resuscitation. But there is one more scenario, uh, when you are performing this resuscitative measures, but the newborn is not responding. So when to stop that? Basically, this is a very, very, very difficult question. It's not difficult question for me to answer, but it is a difficult question or difficult decision taken by any doctor who is performing this resuscitative measures. So better to involve, a senior pediatrician who will decide what to do. Okay, because it's always like a difficult decision to make. Either you should stop now or not. Of course, if the baby is taking longer to respond to resuscitation, there is less likely chances that they are going to survive. Also, even if they will survive, there is less chances, that they will do good, because if their oxygen level is down, there is less blood supply to the brain for a long period of time. So it is going to damage their brains. It is going to cause a lot of hypoxia or hypoxic ischemic encephalopathy. Okay, so if there is no breathing or cardiac output, like 7 minutes is the time, guys. They say like if there is no blood supply to the brain for 7 minutes, for example, there is a lot irreversible damages already done. That even if the patient heart will start beating again, there will be a permanent damage to the brain. So that one of the exception is what, like if someone blood body temperature is too low or there is hypothermia, then of course the thing is different. But that's why, one of the thing, like if there is no breathing, there is no circulation for at least 10 minutes, or after doing effective resuscitation for 10 minutes, so there is no, you can say there will be no good outcome of doing more resuscitation, because the brain damage is already done. Okay, but of course, like this decision should be taken by a senior pediatrician, of course. Okay, either to give up, either to stop resuscitation. Okay, so this is all about like the resuscitation measures of which we do to the baby. Okay, and when to stop doing resuscitation measures. Okay, but like of course, like few of the babies, most of the babies, newborns, they do good. They start breathing themselves. So I took one name that is called as hypoxic ischemic encephalopathy. Of course, what is that? In perinatal asphyxia. Perinatal means what? Like during when it's a fetus. So sometimes the placenta, or due to any reason, there could be less blood supply to the baby. Okay, to the fetus. So what will happen? simply. I'm talking about right now. Hypoxic ischemic encephalopathy. Okay. So what I'm saying is, what will happen, guys? Like if there is less blood supply to the brain, for for example, for a short period of time, simply. Um, what will happen is, there will be hypoxia, there will be hypercarbia, and there will be metabolic acidosis. Okay. Now, of course, when the tissue perfusion is not good and uh, there is less blood supply to the brain, okay, it can cause some brain damage, which can result in disability. Of course, when the babies they start growing, they lack in many developmental milestones because they had a permanent brain damage. Okay, like the incidence nowadays is decreasing, but you can say on an average 1 in 1,000 babies, they can have this condition. So there are many reasons. It could be anything like the placenta fail to provide enough gas, or sometimes while during labor or inside, there is compression on the umbilical cord. There is less blood supply to the baby. Okay, mother have hypertension, hypotension, and anything. For example, the baby they fail to take breath after burn, and it need a lot of resuscitation for 3, 4, 5, 6 minutes. Okay, so of course, like there is some sort of damage will occur to the brain. Okay, one of the thing uh, uh, like the clinical manifestations, you can say the clinical signs of this hypoxic ischemic, this is not X, this is C, ischemic encephalopathy, you can say, are evident like around 48 hours after birth. Okay, and we can um, classify them as mild, you can say, or moderate or severe. Okay, based on the clinical features we got. For example, in the milder form, the infants they are irritable. Okay, and there is hyperventilation, there is impaired feeding. In moderate form, you can say what happens is these infants show, like you can say, abnormal abnormal tone, okay, and movement. Okay, they may have seizures, for example. And in severe form, guys, they are the one, like they don't have movements. Spontaneous movements are not there. And when you will even apply with them with some painful stimulus, they don't respond to that. Okay, sometimes you can found like all their lower limbs or in their body they have hypotonia or hypertonia, too stiff or too floppy babies. And sometimes we can see the effect on their organs, like they have kidney failure, they have liver failure, thing like this. Okay, so not much can be done for this hypoxic ischemic encephalopathy. Why? Because most of the time this damage is some sort of permanent damage. Okay, but just to try, of course, like we give them respiratory not much can be done for them. Respiratory support can be given to them. Okay, as well as we can perform them with EEG. We can give them anti-epileptic medications because they have brain damage, so they can have seizures. Okay, we can monitor them. We can monitor their electrolytes. Monitor their electrolytes. If we found any abnormality, try to deal with that. Okay, monitor their vitals. We can provide them with fluids and this thing. So of course, like, we cannot do much for this damage. The damage is permanent, but there is some sort of recovery. For example, mild patients, the patients who have mild type of hypoxic ischemic encephalopathy, sometimes they show complete recovery. Okay, but others, of course, they have like they lack a lot of. They never show complete recovery. And why I'm teaching you this thing, guys, because we are going to study something called a cerebral palsy. Okay, later on, not today, but later on in the coming lectures, after when we will finish what you can say the neonatology, because we are now covering neonatology topics. So cerebral palsy uh, basically are those babies who have this hypoxic ischemic encephalopathy. There are other causes as well, okay, but simply like later on they present with cerebral palsy. Okay, so this thing uh, is important, guys. Uh, Now, see, like this is system damage by asphyxia and perinatal period. I was talking about this thing. Okay, of course, like there can be a lot of other presentations, but of course I did not talk about all these things. Okay, and here they are talking about the same resuscitation which I show you in other, what you can say, pictures, photographs, right? Now, not thank you for listening. I want to discuss a few more things. Okay, there are some sort of birth injuries which the babies may have. For example, one thing is called as caput succedaneum. What is this one? During birth, the babies, if you will put these terms in the Google, you can see the pictures, Uh, like the part which is the presenting part. Presenting part is the part, during pregnancy, sorry, during labor, the part which comes out first, which is most of the time in normal pregnancies is the head. So because of the pressure on that part, you can find edema over that part, over the presenting part, you can say. Okay, and which is the head, of course. So it is present on the head. Okay, so we call it as caput secundum. Sorry, succedaneum. Sometimes there can be a hematoma on the head. We call it as cephalohematoma. Okay, and what is this one? Simply hematoma, which is bleeding below the periosteum. And why this thing is important, guys? Because sorry, it is not hematoma, it is hematoma. So it is bleeding under the periosteum. Okay. So now, of course, like there is bleeding, big hematoma under the periosteum. So what happens is, like, when the baby they are born, after a few days, that's what is absorbed. But one thing, uh, because this blood is taken by, what you can say, the reticuloendothelial system, and that blood is broken down again in bilirubin, biliverdin, okay, so on and so forth. So these babies are those, uh, who may present with prolonged jaundice. Okay. So rest, like there are many type of birth injuries. For example, there is obstructed labor, and sometimes there can be fractures, especially fracture to the clavicle can occur during the birth. The prognosis is really good, even if there is fracture. Okay, so there are a lot of type of birth injuries, guys, which can occur. But during the birth, most of these birth injuries, the outcome is good. And of course, we are going to study all these things in the coming days, about these birth injuries and all this stuff. So simply, as soon as the babies are born, of course, some of the babies, they need this resuscitation. And by the way, most of the babies, who are preterm, they need more resuscitation. Okay, so if the age is less, more chances of getting resuscitation, like of needing a resuscitation. If the baby is a term baby, there is less chances that they will be needing resuscitation. Okay. Post maturity, once the baby size are as big, of course, it takes more time for them to pass through the birth canal, so they may go into obstructed labor. Okay. So this is the important thing, guys. Before going off from the lecture, because like we are going to discuss about the things, uh, in the coming days, like all the condition which neonates may have. Okay, so uh, like we are going to discuss different terms in the coming days. Many of the babies, of course, like the starting thing is respiratory depression. Okay, respiratory depression. So, what are the causes, etiology or causes of respiratory distress in newborn? Okay, what are the thing I told you already? Opioids, right? So, etiology of respiratory distress in newborn. So, what are the things which can cause respiratory depression? For example, uh, there can be some pulmonary problems like respiratory problems. Respiratory distress syndrome is one of them. Okay, or CNS depression is one of them by the effect of the drugs, for example. Meconium aspiration syndrome is one of them. Pneumonia can be there. Okay, pneumothorax can be there. As well as congenital problems like congenital problems. Okay, so anemia can be one of the cause of respiratory depression in newborn. Okay, anemia can be there. One of the thing. Um, Maybe the maternal causes can be there. Maternal causes can be there. Maternal causes can cause respiratory depression in a newborn. For example, if the mother is taking some drugs like opioids or anesthetic drugs, which the anesthesia people they give her anesthesia like magnesium sulfate. Mother have diabetes mellitus. It is one of the cause of respiratory distress in the newborn. Okay, maybe sometimes mother have myasthenia gravis. Myasthenia gravis is an autoimmune condition in which there is autoantibodies against the acetylcholinesterase receptors. So what happened? Like these are the people who feel very weak during the end of the day. What happens is like sometimes these antibodies can cross the placenta and can present in the baby. So when the babies are born, they have like myasthenia gravis symptoms. Okay, they appear weak, but like the good thing that is transient for a short while. They feel better after a while. Congenital malformations in babies they can lead to respiratory distress. For example, uh, there is a lot like spinal cord defects and sometimes phrenic nerve injury, things like this. Okay, shock. That's why we give normal saline. Shock can also lead to respiratory depression. For example, antepartum hemorrhage. What is antepartum hemorrhage? If the mother had too much bleeding during the pregnancy, during the labor. Okay, postpartum is after giving birth. Antepartum is before or during giving birth, right? peripartum is during, antepartum is before. So of course, like if they have a huge amount of bleeding, okay. Rest is very small causes like hypothermia can cause respiratory depression. Hypoglycemia can cause. And that's why, when the babies are born, what we do, we do a lot of labs. By the way, very good, I was about to finish the lecture, but I remember, like, what are the labs we can do, okay, in a newborn baby. What are the labs you can do in a newborn baby, okay? So, see, when the babies are born, I told you we can see the vital signs. We like the baby mother history, and during the labor, what drugs they have taken should be at your hand, okay? You must know if the mother was having any infection. You must know either the mother has taken any drugs, what kind of drugs were given by the anesthesiologist, right? So, what labs we can do for the baby, for the newborn, just to rule out or think about why they're not behaving normal, why they need more and more resuscitation, okay? What labs can be done? Of course, like go for the basics first. CBC. For example, I will tell you, infections can also lead to. Many of the mothers, they have preterm rupture of membranes. Like there is the membrane in which there is amniotic fluid. So sometimes their membrane get ruptured few hours or few days before start of labor. They can have infection of that called as amnioitis. The baby can get that infection as well. So maybe the baby is born with infection. Okay. Maybe the baby contract infection while passing through the birth canal. So we can do CBC. Okay. Though the signs and symptoms of infection in the newborns or in too young children, like the neonates, are not typical. Maybe when they have infections, they can present with hypothermia. Maybe when they have infection, they present with hyponatremia or neutropenia, lymphopenia. So they have a very, you can say, diverse type of signs and symptoms, not typical. ABGs, atrial blood gases, will tell us what is the oxygen level, what is the carbon dioxide level, what is the pH in their blood, okay, how much is the bicarbonate ions, which will give you a very good idea. Either you have to give sodium bicarbonate, okay, what kind of fluids you can use. A very good lab you can do is to check the blood group of the baby. You can decide either the mother need any RHO-GAM, like if the mother is blood group negative. In OBS, you will study that thing in detail. Very good thing. See, hypoglycemia can cause respiratory depression. You can check the blood or plasma glucose levels, PGL, plasma glucose level. By the way, I should. Plasma glucose levels can be checked, okay? If you are suspecting like pneumothorax or any problem with the lungs, pneumonia, we can go for chest x-ray. Okay. By the way, chest x-ray is not always needed because in emergencies, they can do a trans-elimination test to check for pneumothorax, okay? Thorax. So guys, that's all about, I think, like this topic. And what we will be doing in the coming lectures, we are going to study the common conditions of neonates. Like we'll start with apnea. Respiration is very important, okay? Then we'll do bleeding disorders. We will do cyanosis, for example, okay? We will study the signs of like causes of cyanosis. We will discuss that. We will discuss hypoglycemia. We will discuss hemorrhage. Jaundice is very, very, very important. We will discuss that, okay? In the next week, of course. And we will discuss like all these topics, with the things which can occur in newborns. We'll discuss sepsis, okay, like all these things in the next week. or next weeks, you can say 2 weeks, we'll take this thing, and then we will move on the systems like respiratory, cardiology. I will teach you congenital heart problems and all this stuff. So thank you so much for listening, guys. Until next week, take care, stay safe. Bye bye.